Okay, for this lesson we're going to do the upper GI images that are necessary if you are doing a series with a doctor, with a radiologist, and he says go ahead and do the images. So I'm going to run through all of the different images we might do, and we always do these in order that is easiest on the patient. So I'm going to start with her facing up. She's got shielding on, and they're upper GI pictures, so the stomach's always on the left unless you have a particular situation with situs inversus. And so we're just going to not put a left marker on it because the stomach's always in one place, pretty much. It does move and have different formations according to the habitus of the patient. So first of all, we're going to do the AP, and I'll try to think of some things to help you with as we go through this. So I have a 10 by 12 crosswise in the Lucky Tray. Of course, if you're using full digital, you would just do a 10 by 12 collimation. And we're going to find the xiphoid and go down 2 inches and move about 1 inch to the left. And I've done the halfway between the xiphoid and the crest. Might move that just a little bit. And then just a little bit over, and that would be the AP. The next projection is the LPO. So our patient is laying 45 degrees and on her left side. So this is a lengthwise IR. And we're going to have her 45 where she is already. I've placed her there. And we want to find the xiphoid again and come a little to the right with the centering, and then down 2 inches. So xiphoid over 1 inch and down 2. And our goal for this is to get all of the stomach. This may seem like you're centering on the right side, which you are, but it is actually centering right over the stomach. So that is the LPO projection. So for this next projection, I've rolled my patient up onto her right side. She's got her shoulders, as you can see, going that direction. We need to line her up a little better. The way I would try to get my patient to do that is to just tell her, I'm going to move you just a little bit. I'd reach back under her elbow closest to the table and just pull her back a little bit. Then I could straighten her up and adjust her as needed. I have found over the long run that the more you try to explain for them to do something, they can't. So if you're in a rush to get something done, it's easier just to move them a little bit, warning them ahead of time, of course. So for this one, I find the crest, I find the base of her scapula, and I'm going to go halfway in between. And then I'm going from the coronal plane, I'm going about 1.5 inches to 2 inches anterior. And as I look at her, of course, everybody's habitus is different. I want to include as much of anatomy as I can. And so, since my patient isn't overly big in the front, in her stomach area, I would move my cassette back just a little bit, my centering back just a little. I have everything in the front, and I can get a little bit more toward the spine. So this is a nice right lateral. In this case, what I would do is mark the cassette with an R, because right laterals and left laterals can be both done, and it depends on what the doctor orders. So make sure to mark your laterals with a right or a left, anterior to the patient and down to the lower corner. I'm just going to show you the right lateral today. If you need to do the left, it's exactly the same. This projection is the PA, and I have to change my IR so it's crosswise. And then I've had my patient turn over onto her stomach, but she's kind of not straight, so I'm going to straighten her body out some. And come to the top, double check. She's still a little crooked. There, that was a little better. Now I'm going to find the tip of her scapula. The stomach lives over here. It's on the left side. Scapula, crest, halfway in between, and centering a little bit to the left. Collimate to our 10 by 12 crosswise. And I include here, but she's not very big, so I'm trying to get over a little bit more centered because I want to get as much of the area here as possible. And there's the PA. The next projection is an RAO, and so I'm going to do my IR lengthwise. Don't need a marker. Change my collimation to lengthwise. My patient is in a 45-degree angle, her body is. I'm going to find the scapula and the crest, go halfway in between on the up and down, and then I'm going to center about an inch back toward the spine. And you want to eyeball this because every patient is different. You want to make sure that you always get the front part of the stomach. So the calculations you see in your Merrill's or whichever book you use may not always be correct for that particular patient. So they are only guidelines. You need to know where the stomach moves and how it does. The more exams you do, the more you'll learn about where the stomach will be. But that gives you the basics for finding the stomach. And that's the RAO. The last projection for the upper GI series is always done last. So this is a 14 by 17. You center it an inch above the xiphoid. So my top border is an inch above the xiphoid. I center my light. And I have an arm marker on the right side. And then I'm going to center her. So basically it's a KUB, but we're a little higher because we want to see the entire stomach, and we want to see how the barium is moving through the small bowel and hopefully into the large bowel. It's mandatory that we do this exam last, this particular projection last. So it's like a KUB, only it's higher. In fact, I think I'm going to move it up just a little bit on her. The goal is to make sure you get the entire stomach. The stomach sits just under the diaphragm, and so we want to be sure we're above the diaphragm. So I will give you an addendum on this projection in just a second.